GVHD, ideally we would have done a bone marrow harvest on the donor, but theater expertise to do a bone marrow harvest and then handle the stem cells was limited, so we went for peripheral blood stem cell. Transplants in severe aplastic anemia are associated with higher risk of EBV and PTLD, so we added rituximab to prevent this because EBV monitoring every week is very costly. Patient was nursed in strict isolation in a dedicated unit with strict adherence to neutropenic care, in strict isolation with nurses dedicated to the unit, OBS every 4 hours, and neutropenic antibiotics, broad spectrum, tazocin and gentamicin at the emergence of a first temperature. All blood products were irradiated. So in summary, we can see from the charts, day 0 is the day of transplant. There were 5 days of conditioning before that, but I hope we can see that all blood counts, neutrophils, platelets, and hemoglobin improved significantly after the transplant, and that has been a sustained ongoing normal blood count post-transplant. He's currently 1.5 years post-transplant. He has very mild liver GVHD with a normal bilirubin but a raised alkaline phosphate, and so we're gently weaning this immune suppression, but he remains on prednisolone and cyclosporine. He's growing well and due to return to school. So I'd just like to say, we're happy he's doing very well, 1 year, 6 months post-transplant, but also that it is a challenging procedure to deliver in a resource-limited setting. And there's a lot of adaptation required behind the scenes in order to make established protocols doable in our setting and maintain quality and outcomes. And the main challenges include lack of availability and supportive care. Some of the ways of overcoming this is I had meetings with pharmacists 6 weeks in advance, ensuring every single medication that you think you might need, together with the ones you definitely need, are in the hospital before you start conditioning. Sourcing blood products, simple ways asking the family to identify friends, not family members, who will come and donate at the time. And there I've had 14 years of experience as a BMT consultant, and you really need a deep understanding of transplant and the nuances to understand how to adapt here. Also, the post-transplant follow-up is super important. It's not just that you've done the bone marrow transplant and your patient is okay. Complications happen 3 months, 6 months, and a year. And thank you. Just one more thing to say. Having a transplant at home, you can eat ugali. You don't have to eat other things.
Thank you, Dr. Rohini. I think that was an excellent presentation on a complex procedure. Hopefully, there will be many more that will happen in our country. Our next speaker is Dr. Gloria Omondi. She's going to talk to us about response rate after neoadjuvant systemic therapy for breast cancer at Kenyatta National Hospital. Welcome, Gloria.
Good afternoon, everybody, and thank you very much, Kesho, for this opportunity to present our study. We carried out this study with a number of my seniors and mentors. The topic of the study was response rate after neoadjuvant systemic therapy for breast cancer at Kenyatta National Hospital. So just a bit of background. We know that neoadjuvant systemic therapy has several useful indications. It's important in downgrading the stage of tumor to allow better surgery. It's an opportunity for testing in vivo response to treatment, and it provides guide to adjuvant therapy, especially in the HER2 positive and triple negative breast cancer, for example, in the KATHRINE and the CREATE trial, respectively. We know that now we know that pathologic complete response after neoadjuvant systemic therapy is a strong prognostic factor for long-term outcomes such as disease-free survival and overall survival. So our objective was to determine the response rates after neoadjuvant systemic therapy for breast cancer patients over a 5-year period. That was between 2018 and 2018 and 2022. We defined pathologic complete response as the absence of invasive tumor, both in the breast and in the draining lymph nodes in the surgical specimen after the neoadjuvant chemotherapy. And we used chi-square to compare different variables, and we set our significance level at a p-value of less than 0.05. And we also assessed the one-year outcome of these patients. So if you look at this chart, when we looked at the Kenyatta National Hospital records, and we managed to retrieve 1,314 files, and out of these, quite a large number, 1,094 patients were excluded. The majority, over 500, were excluded because they already had adjuvant chemotherapy. About 290 were excluded because of palliative chemotherapy in metastatic disease. Then we had about 130 patients who were excluded because they got chemotherapy outside Kenyatta. And this is common because we are a referral center. Patients get treated outside and then get referred for radiotherapy and further treatment. So out of this, we ended up with 220 patients who had neoadjuvant systemic therapy prescribed at Kenyatta. But still out of this, 36 of them ended up having local disease progression. 11 of them had metastatic disease progression. About 30 were lost to follow-up. And 5 of them, we did not get their surgical pathology reports, and this was a requirement for inclusion into the study. So out of that, we ended up with 138 patients. So when you look at our results, what I want to highlight is that the median age of our patients was 46, quite young. Majority of the patients, 97.8, were females. And I want you to note that if you look at the T stage, about over 97% of the patients actually had T3 and T4 cancer. And when you look at the end stage, again, over 93% of the patients were node positive. If you look at the immunohistochemistry profile, HR positive were about 44%. The HER2 positive were the majority of the patients at 38%, and the triple negative patients were 17%. In treatment, over 90% of our patients got both anthracyclines and taxanes, and about 18%, that's 18% of the patients had HER2 targeted therapy. And of note is that the targeted therapy was just Herceptin. None of the patients had dual HER2 treatment. If you look at the treatment response, 25% of the patients had pathologic complete response, and the response was highest in the patients with HER2 positive disease, especially the ones who were HER2 positive and hormone receptor negative. And immunohistochemistry was the only factor that was associated with with the response rate. So at 1 year, we had 81% of our patients. At 1 year, we had 81% of our patients who were disease-free. 4.4% had local recurrence, and 10% had distant recurrence. So in conclusion, a significant number of our patients coming to Kenyatta Hospital still had upfront surgery followed by adjuvant chemotherapy. But you know that neoadjuvant systemic therapy should be the best practice, especially for those with HER2 positive and triple negative subtypes, and not just those with locally advanced disease. Most of the patients received neoadjuvant chemotherapy had larger tumors, node positive disease. A quarter of our patients achieved PCR, and this was mostly in those with HER2 enriched disease, even when the HER2 therapy was not used. Note that HER2 therapy was only given to 44% of the patients who had HER2 positive disease, and over 80% of our patients were disease-free at 1 year, and we plan to do a long-term follow-up. Thank you.
Thank you very much, Dr. Gloria, for giving us an overview of the response of neoadjuvant chemotherapy for breast cancer patient KNH. Our next speaker is Dr. Fiona Adagi. Her topic of presentation will be disengagement from care among patients with breast cancer at Jaramogi Oginga Odinga Teaching and Referral Hospital, JOT, in Kisumu, Kenya, where we are being hosted. Welcome.
Thank you for that kind introduction, and I'd like to take this opportunity as well to thank KESHO for the opportunity and selecting this abstract. So we looked into the disengagement of care among patients with breast cancer at JOTRH in Kisumu, Kenya. So a quick introduction. Breast cancer incidence and mortality are increasing in African countries. Although screening and treatment options are available, significant gaps remain that contribute to these poor outcomes. Failure to engage in care may negate the beneficial effects of prevention and treatment. So we had sought to evaluate the risk of disengagement from care among patients with breast cancer at JOTRH. So it was a retrospective cohort study. We included all diagnosed with breast cancer at JOT between January 2014 to December 2023. The disengagement, we had defined it as being more than 6 months from late for the last clinic visit. Factors associated with disengagement, we determined using multivariable Cox proportional hazard regression model. So the results, patients that received no treatment had a significantly higher risk of disengagement from care than those who received any treatment, with a confidence interval of 1.71 to 2.21. And among patients who received treatment in combination being chemo, surgery, or radiotherapy, had a significantly lower risk of disengagement at a 95% confidence interval of 0.35 to 0.73 compared to those who received single treatment. So when you look at time from diagnosis to disengagement by treatment modality, the time was in days against treatment modality. We noted that those who received chemo alone, the median time was 289, and those who received combination had a longer time of 365, and those who never received treatment alone had a shorter time of 55.5, and those who received other treatments like hormonal therapy among the other combination therapies, the median was 407, and the ones who received surgery alone was 322. So in conclusion, we found that the risk of disengagement from care of patients diagnosed with breast cancer was higher at 58%, and the highest among those receiving no treatment or one type of treatment as compared to those who are receiving combination therapy. And in recommendation, future work may explore strategies to help patients with breast cancer initiate and complete treatment. And as well, for those receiving combination treatments, patient navigation could help patients maneuver complex treatment journeys that might include visits to other hospitals and radiotherapy. I'd like to acknowledge the JOTRH staff, the staff from University of Washington, and my mentors, Dr. Thomas Oden and Angela McLeod. Thank you.
Thank you very much, Dagi, for keeping time. You have saved us 1 minute and 25 seconds. A round of applause for her. Let us applaud the whole audience for keeping time. I think this is the session which all the speakers were able to keep time. A round of applause for them, please. So at this moment, we would like to check quick questions. Just as the speakers made it rapid, please, the question should also be very fast, precise, to the point. You have only 10 seconds to ask your question, and we would like to encourage each speaker for one question. Okay, ready to go. Who is ready?
Okay. Could we have a mic here?
Carol Kilach. My question is to Rohin. What are your thoughts about care post-transplant, especially as you see many people going to India and they're coming back to different county facilities and expecting their post-transplant care to be better?
I think that's a great point you've raised, because I have huge concerns about that. The first 3 months post-transplant are not the most eventful. The challenges I've seen personally, I mean, you all will know a lot more, is that patients often run out of money by the time they come back. And so you can't do the monitoring for CMV, cyclos. They can't afford rejection drugs, particularly important in sickle cell transplants. You need to continue immune suppression for at least a year. And as you can see from our case, 1.5 years later, he's still on a small amount of immune suppression. So I tailor it and treat it. So I think the post-transplant care has to go past 3 months. And we have to, if we get an opportunity, can we counsel our patients? If we hear someone is going, can we counsel them? They need to be prepared for when they come back financially and find a center that can assist.
Thank you. I think the question was very rapid, precisely, and the answer almost precisely. Thank you. Let us keep time. Next question, please. Prof. Abinya.
Thank you, Dr. Dagi. Do you know the number of at least T3, T4 tumors who had surgery before any form of systemic therapy?
From this study, we just picked all patients. But if I'm to answer that, the number of those who are T3, T4, the dashboard that we presented the other day, we saw that most of our patients we see are in stage 4, but we see a bit of T3. So I'd put them at roughly about 200 patients annually. Yes.
Thank you. Next question for another speaker.
I have a question.
Sure, go ahead.
So my question is, Dr. Nyongesa, when you said that the toxicities were similar, what toxicities for radiotherapy were you looking for specifically?
So still in the early initial stages of assessing, but we are looking at the acute toxicities, the skin reactions. For both arms, it was grade 0, at most grade 2, and there were more grade 2s in the 3-week protocol.
That was very precise as the Wikimoja. Very brief. Thank you. Next question. Yes, please, go ahead. The microphone should also be very precise and short. Okay.
Good afternoon. My question goes to Hawa, on hypofractionated prostate treatment. In terms of the consideration, which protocols are you using in terms of the constraints evaluation? Is it Quantec or Alford?
For our case, we used the RTOG because the dose was more than 2 gray.
Okay, thank you.
Welcome.
I have a question for Dr. Pascalia. I know that you did your study in China. Is it going to be reproducible in our setting?
Yes, but we will not use the same technique. So I intend to actually compare it with some studies we've done here using anatomical studies, using cadaveric studies, because we do not have access to the 3D reconstruction machine.
Final question? Quick mic. Very rapid, very rapid.
Thank you. My question is for Dr. Adagi. I noticed that majority of the patients who are lost to follow-up are patients who hadn't received any treatment whatsoever. Is there a consideration that they might have sought treatment outside, but also if these are people who don't receive any treatment, you have a very comprehensive service. Are you going to engage community workers to seek out these patients?
Thank you for that question. And like I'd put in my recommendation, from this abstract that I presented, the results had shown that those who never got treatment at all or got a single treatment had a higher risk of disengagement. So the recommendation was, yes, there are some patients that we refer out to other centers, majorly at times if they're going for chemotherapy, or maybe if they're going to sort treatment to a facility near home. I'd recommended that having at least a better patient navigation system for us to be able to as well at least link them up, if you're referring them for radio, to the facility that they are going to, would help at least us have a bit of some data about them. Thank you.
All right, thank you. I'd like to round it up of applause. I think this is the session that has had the best time management, so we'll clap again for them. I'd like to invite the speakers to the front for a photo, and then we'll move on to the next session rapidly.
So our next session will be the closing ceremony. At this moment, I would like to invite the following people to come to the stage. I would like to invite the IOTIC president, Dr. Miriam Mutebi. I would also like to invite the KESHO interim president, Dr. Elena Musau. I would like to invite the CEO of Kenyatta University Teaching, Research and Referral Hospital. Finally, I would like to invite the First Lady of Kisumu to come to the stage. So we'd like to begin with our closing ceremony. First and foremost, I would like to thank everyone for being here for the 3 days. The first speech will be coming from the IOTIC president, Dr. Miriam Mutebi, who also happens to be the past president of KESHO. Welcome.
Thank you, Dr. Obeid. And I apologize, I've managed to pick up a nasty throat infection, but we'll try and muddle through. My name is Dr. Mutebi. I'm a breast cancer surgeon at the Aga Khan University and the current president of the African Organization for Research and Training in Cancer. And really at this point, standing between you and lunch as the penultimate discussion before this ceremony. And I think part of the things that I wanted us to do is maybe shift gears a little bit and look at some of the work that's been done by Binyavanga Wainaina, who many of you might not know, but is one of, the late Binyavanga is one of the, I would say, foremost authors who wrote about comedy and satire in the region, but he wrote this seminal work around how to write about Africa about 20 years ago. And we sort of thought, well, maybe let's shift gears a little bit and reflect on are some of the tongue-in-cheek references that he said really true in this day and age. And so as part of his nomenclature, he says the first thing is always use the word Africa, and then use darkness or safari in your title. I think we've covered that by saying cancer care in Africa, so we do have some reference around Africa. But looking at, despite referencing safaris, we are known as Africans for our vibrant culture, whether it's, of course, our runners, our vibrant culture, our imports to the modern world, including by which we mean the humble coffee bean. We do know that it is a good time to be African. We are seeing the highest growing economies despite the pandemic. We do have, despite deficits in the workforce, we are seeing more and more of the workforce getting skilled across the continuum. And so looking at what is the next bit that Binyavanga sort of references, and he says, always write about Africa as if it was one country, which we know is completely false, because even if we go from Kisumu to Nairobi, we know there's a lot of heterogeneity that exists, but also in terms of, even when we're sitting in clinic, you're having to change sometimes your treatment strategies based on who you're seeing from one patient to the next. And so we do know that despite the heterogeneity that exists, there is opportunities to consolidate or homogenize care in these settings. But it's important to realize that Africa is not a country. Cultures differ. Context and timing matters. and consistent engagement with whichever health system we're interacting with is key, and it's important to leverage existing networks for us. We do know that despite the efforts that we've seen increasing even in the last 10 years, we do know, however, that 70% of deaths are still occurring in low and middle income countries like ours, with about 5% of the global oncology resources being used in this setting. So what does that translate to in terms of how do we shift how we write about Africa currently? Through the African Organization for Research and Training in Cancer, what we've done, or what we really envisage, is a continent where everybody, every patient, irrespective of where they live, has access to safe, timely, affordable cancer care. And so our objectives are around increasing research relating to cancers of relevance in Africa, or high burden cancers, supporting training programs for healthcare workers and researchers, and dealing with the challenges of creating cancer control programs in whichever context we're in, but really trying to elevate the conversation around cancer care in Africa across different settings, just based on the ability to raise awareness around this. So we do, sorry, 2 seconds. We do have a council structure, and we are, pleased to have regional representation. We do have a treasurer and a secretary general, but we do have regional VPs, including Dr. Sidna Mwanzi, who is the VP East Africa, and Dr. Ibrahim Abiola, who have joined us for this session, but also trying to ensure that instead of brain drain, we enhance brain circulation by tapping into the diaspora and having representation from North America and Europe, but also looking at areas which we feel are priorities, like the VP nursing and the PALOP, which are the Portuguese countries which have traditionally lagged behind, and really bringing everybody to board in terms of that. We're proud of the history that we've achieved so far. We're saying Aortic is 40 years old, and I would say Aortic has had a long and vibrant history and partnership with KESHO, all the way from our patron, Prof. Nicholas Abinya, who is critical in shaping some of the strategies around the direction for Aortic. And we've had the biennial conferences, we have an Africa Cancer Genomics and regional conferences. And what we have, because we have 1,200 members who are really across the entire continuum, all the way from cancer advocates, civil society organizations, researchers, clinicians, policymakers, is really trying to develop special interest groups or communities of practice that help to distinguish, or at least provide areas, niche areas of engagement in tackling the challenges of cancer in Africa. We do have some research initiatives, part of which is our flagship, the Big Cat, that's really beginning catalytic grant for young researchers who are looking to build their career, leadership training, including the African Cancer Leaders Institute that has been in existence for the last 10 years, and through our collaborations, different mentorship and partnership programs. Our last conference in Dakar last year had about 1,000 participants from 64 countries. But looking at taking a step back as we turn 40 has really been, how do we start to align to the Sustainable Development Goals? How do we really have that robust discussion around universal health coverage, and how does that refer to oncology patients? How do we start to, as clinicians, get out of our clinics and engage more in Pan-African policy that relates to training, research, and health, and be part of the African Union, really looking at the Africa we want and how we can start to align with this. Binyavanga says, always write about wise old men providing wisdom. We do know that with the advance and democratization of knowledge, I would say the knowledge is not just the purview of a select few, but then looking at how well are we enhancing or developing this knowledge around cancer. We do know that a bedrock of any cancer research or cancer control programs lies in research. So how well are we doing as a continent in terms of getting our alignment between data-driven research and policy? Through the African Organization for Research and Training, and in collaboration with King's College London, we try to look at, so how have we been doing over the last 10 years? And we looked at about 24,000 papers and tried to look at how much research is being generated. And what we found was that oncology research specifically, and this perhaps should be an opportunity for all of us in the room, is only about 8% of all African health research. And what we noticed was the majority of cancer research, was about 67, was actually from the 5 North African countries. And I think it's an opportunity for us because the 49 countries in sub-Saharan Africa only presented about 14% of all the literature that was generated. So how are we doing in terms of the literature we're generating versus the disease burden? We all know our top disease burden, our top priority cancers are breast, colorectal, prostate, cervical, and esophageal or GI cancers. But looking at the graph, and to the left of the graph are the cancers that are, having research that's commensurate with their disease burden. So things like blood cancers, breast cancers are having an appropriate amount of research. But if we look to the left of the curve, things like liver cancers, cervical cancers, colorectal, prostate, ovarian, esophageal, all of which are high burden cancers in our setting, are really underrepresented in terms of the research that we are generating. And if we look at, okay, so what are some of the drivers that could be pushing this? Why aren't we doing as much research? And looking at maybe what are the differences between the countries that have the highest amount of research and the countries that aren't. And looking at the top 5 cancers, which are top 5 countries, which are from North Africa, what we notice is that the highest initiators, all these countries are really having a high research output because it's country-led initiatives, meaning that they are deliberately investing. Kenya, we're somewhere in the middle, which means we have definitely opportunities to expand this. And I think we've had promising initiatives that have been announced through the NCI and the National Research Fund, really underscoring the need for us to amplify and expand on this. Through AORTIC, we've tried to look at how do we then help support countries, clinicians across the continent. And part of what we've done, Turning 40, has been looking at our strategic review, where we've been looking at how to consolidate our key strategies and developing a 4-year work plan across these settings, but really looking at how can we have 3 main streams that, 1, develop an organization that's more member-facing, 2, harness our advocacy role, and really strengthen our convening capacity. And this is an invitation for everyone in the room and all potential collaborators to look at how we can collectively work together towards this. Through our convening capacity, we've had the benefit of having our members as either researchers, policymakers, as technical members of working groups with ministry, but in also designing and tailoring and curating courses for the different cadres of healthcare providers, whether it's radiation oncologists, whether it's through research integrity series, or actually going to the grassroots and training the primary healthcare providers in signs and symptoms of cancer, which are part of the courses we are currently running. And through our advocacy, looking at how do we train our our advocates to actually know how to sit on IRBs, ask the right questions, and ensure that they are speaking in a language that policymakers or researchers understand. Through our research initiatives, again, we've been looking at building research that is appropriate for the continent. For instance, we've just completed a study on the language of cancer, and I think throughout the course of the sessions, including yesterday's session around the importance of how we speak to patients and how it makes a difference. The language of cancer can ensure that we're either engaging, as Dr. Fiona said, or perhaps not retaining patients in the system. Simple things such as telling the patient, basically translated that we're going to chop your breast, burn it, and then give you poison, may not perhaps encourage our patients to engage with the health system. And again, looking at beyond the grassroots advocacy, how translating that into a higher level advocacy, which we're now doing in partnership with the African CDC and through the WHO, Afro, and EMRO situation. So I think in summary, global oncology is an emerging field, and aortic is positioned to play an increasing role, but I think we definitely need all hands on deck, and we do need to really rethink our pooled advocacy efforts. I think we do, again, need to think about collaborative efforts as a region, whether it's in pooled procurement, as we had from discussions yesterday, looking at some of the strategies as we build regional centers of excellence, but recognizing that cancer advocacy requires not just allies and data, so this is an open call to collaborators and an invitation to us, to you all, to engage with our 2025 Tunisia conference that's coming up over the 2nd to the 5th of November, and perhaps a platform to continue engaging with this dialogue. So in closing, Binyavanga, one of his last comments was around always write about Africans enjoying music and drums. Is there any veracity to this? And what we do know is, at least as evidenced yesterday, all of that might not be tongue-in-cheek. We do love our music and dance. I think that is members of the organizing committee trying to set it with various degrees of success. But I would just want to thank you all for your time and attention, to thank Kesho and for their continued partnership, Aortic for this opportunity, and AKU, my home institution, for the time off, and to thank you all for your time. Thanks.
Thank you. Thank you so much, Dr. Miriam, for that insight, what IOTIC is doing. Next, I'd like to invite my predecessor, the head of department at the Kenyatta University Referral Hospital, who also happens to be the KESHO president. Welcome, Dr. Elena Musao.
Thank you, Abeid. He silently told me to do this as a rapid fire session. So I'll try my best. Your Excellency, First Lady Kisumu County Dorothy, the CEO, Mr. Ahmed Dagane, distinguished colleagues, it's an honor to address you today. Abeid. So it's an honor to address you today, albeit in an interim capacity. So Dr. Busakala, who was elected unopposed in 2003 elections, resigned later in August this year. He cited personal reasons. He was, however, grateful to have served as the president of KESHO, and he continues to work very closely with myself behind the scenes in this transition capacity, and he remains a KESHO member and will continue to contribute in that capacity. Following his resignation, we were guided by our current constitution. It allows for a member of the executive to step in and fulfill the roles of the president. The KESHO elders, led by Professor Abinya, were very crucial in the role of this transition. And as it stands today, I am the interim president, Dr. Njoki Njiraini is the interim secretary, and Dr. Irene Zamu continues as the treasurer. The communication for this will be relayed to the membership. As we navigate the transition period, I want to assure you that our society's mission remains steadfast to improve the outcomes of patients with cancers and blood disorders. While the interim period represents a unique challenge, it also offers opportunities for reflection and renewal. So we will continue to prioritize members' needs. By doing this, the members' voice is paramount. With due diligence, we will address your concerns and provide support. We will continue to foster collaboration and strengthen our connection with other societies and organizations, and to expand our networks and knowledge base. We are very grateful for the support that we have received during this conference. We've had representation from Africa and beyond. IOTIC has been here. We've had the Oncology Nursing Society present, the Surgical Society of Kenya, the Kenya Hospices and Palliative Care Association, amongst many others. We've had international representation from ESMO and EHA, as well as others. As KESHO, we will continue to advance our field, where we encourage the use of innovation and also dissemination of knowledge, as we have seen during this conference and also during our weekly webinars.
In our webinars, we usually have over 700 participants joining in, and they're usually participants across Africa. Our reach is not just in Kenya, despite the fact that our mandate has been for Kenya. We reach across the continent. We shall continue to champion ethical practices. We want to ensure that we uphold the highest standards of professional conduct and ethical behavior. We have started a process of a strategic plan, which we hope to share with our membership very soon. And we are working very hard to be able to have our new constitution that we approved during a special AGM held in 2022. So we are waiting for that process with the Registrar of Societies. And we need this to be able to carry out our elections in 2025. I encourage our young members to nominate themselves and others so that they can join in this leadership journey for the society so that we can create a brighter future together. Let's embrace this opportunity and strengthen our bonds and renew our commitment, charting a course to continued success for Kesho. During the course of this conference, it's been a labor of love, chartered with a lot of hard work, a lot of tears, I must say, at some instances. But we've managed to achieve our objective, or the vision that we created for ourselves. We started off on Tuesday, where we screened over 800 people at the Mamboleo grounds. We had 3 successful pre-conference workshops. We had our sessions on AI and technology, and we were joined by His Excellency, the Governor of Kisumu, Professor Anyang' Nyong'o. We were jealous of the dashboard that Kisumu County has, and we hope to see if we can borrow the lessons learned from there for other counties and other centers in the country. Our Cabinet Secretary of Health, Dr. Deborah Barasa, joined us, and she gave her commitment for government in continuing to support cancer care objectives. She mentioned to us about Taifa Care and its role in the cancer continuum, and also the decentralization of services for the population of Kenya. Our SHA CEO was here with us, and he was able to talk to us about the oncology benefits and demystify a lot of what we do not have. We do not understand. These are conversations that will continue beyond this conference, and we hope to be able to engage afterwards. We have had many insightful and exciting sessions throughout the last few days, ending in today's rapid fire, and we hope to use this as a stepping stone for our conference that we shall hold in 2026. So with that, I'd like to say thank you all for coming. It has been happy to meet many new faces. I was not able to meet all of you, but I'm sure you have enjoyed yourself at this conference. God bless you, and God bless Kesho. So I have been tasked with inviting my boss. My boss, but before I do that, I will invite Her Excellency, the First Lady of Kisumu County, to address us in this closing ceremony.
Thank you, Daktari. Just to bring you greetings once again from Governor Anyang' Nyong'o. He says he hopes that you have enjoyed your stay in Kisumu and that you have felt the welcome. On his behalf, I also want to say, Karibuni Tena. I know that I think Kesho has been here for the second time. Am I right, Professor Binya? And I don't think it should be the last time. You are welcome to come again and again. I know you want to go to the other regions and serve the other regions, but please know that you have a home here, and you're most welcome. God bless you all.
Before you sit down, there are some people who have been very instrumental among our faculty members who would like to recognize. So at this moment, I would like to ask the First Lady of Kisumu to come back to award them. So I'll be calling the names not in any order. First and foremost, we'd like to thank Angela McLegayo for successful organizing the screening camp on Tuesday. Dr. Angela McLegayo. Dr. Angela McLegayo was being assisted by Dr. Fiona Adagi. Kisumu can get cold at night, so at least this time will help them to keep warm. Next is Thomas Odeni for the wonderful organization of the grant workshop. Thomas, you are not feeling cold? Okay. Next, I'd like to invite Professor Nazik Hamad for organizing the faculty development workshop. Okay. So, okay. This is Prof. Nazik, my mentor. We are doing together the work on geriatric oncology. Next, I would like to invite Dr. Fidel Bagumia from Rwanda. Okay, I would like to invite Professor Tim Olive. Thank you, Prof, for supporting us. Prof. Tim Olive is one of the oldest friends of Kesho. We can even call him the founder of Kesho in Europe. Okay, so next I would like to invite Dr. Rogers Mongare. This will be followed by Joel Okumu. Dr. Joel Okumu. Next, I would like to invite Dr. Vena P. Velna Vandepuria. Welcome. And finally, I would like to invite the President, IOTIC North Africa, Dr. Abiola Ibrahim. Dr. Abiola Ibrahim was the one chairing the morning sessions today. Is she here? Okay. Thank you so much, the First Lady. You could take your seats. So this year, we want to give special gifts. Remember, at the beginning, we asked you to visit all the booths. So today we are going to have 3 winners who are able to visit all the booths. We are going to give them laptops. This is courtesy of our sponsors, Hetero. Are they already here? Okay, so we'll come back to that. As we proceed, next I would like to invite my CEO, Dr. Ahmed Dagane, who is going to award the best abstracts, the best winners for the abstract, oral presentation, and the rapid fire. So first, we are going to begin. Dr. Jean Kasuri for being the best young presenter at the 8th Kenya International Cancer Conference. Dr. Jean Kasuri, are you here? Oh, unfortunately, she left. She's actually she's one of the youngest presenter here. She did an amazing job. She presented the data from the Kenyatta National Hospital. She was very confident. The data was well presented. Congratulations to Dr. Jean Kasudi. Unfortunately, she's not here. But maybe anyone? Dr. Irene Weru, the supervisor. So she was being supervised by Dr. Irene Weru. So you present this one from this end. A round of applause. Our next award is the best oral abstract, which is going to Dr. Evangeline Giro. She presented a wonderful presentation of hepatocellular carcinoma. Dr. Evangeline Giro. Okay, I think she has left. Anyone representing Evangeline Giro? Okay. Next is the best poster abstract. This is going to Gabriel Christos Hegos from Somalia. So, Dr. Gabriel Christos Hegos from Somaliland. Okay. I think he has left. And finally, would like to... Okay, Dr. Njiro is here. Okay, welcome. So the Kisumu people have decided the best rapid fire abstract, it needs to remain here because it was very hot and rapid for them. So the winner for the rapid fire abstract is none other than Fiona Adagi. Congratulations to all the winners. At this moment, I would like to invite the CEO of KICC to address us briefly. Thank you.
Good afternoon. Good afternoon, everyone. Before I read my speech, this is a wonderful event. It's indeed an international event. Can you clap for Kesho, please? The president of African Organization for Research and Training in Cancer, AORIC, the interim president for Kesho, Dr. Helena Musau, the distinguished members of Kesho, esteemed guests, ladies and gentlemen, good afternoon once again. I also want to echo the sentiments regarding the leadership of the great county of Kisumu. I had called the governor last night, and I told him, Bwana Governor, I've arrived in your great county, and he had asked me which hotel I was staying, and I was surprised that he paid me a visit this morning. So Madam First Lady, you are not only married to the greatest brain here in Kenya, but also a humble man. We do appreciate that leadership. I'm deeply honored to join you at the 8th Kenya International Cancer Conference, a platform that has fostered insightful discussions on critical issues in oncology. Cancer remains the third leading cause of death in Kenya, following infectious and cardiovascular diseases. This reality underscores the significant public health challenge that cancer poses, threatening the stability and development of families and communities across our nation. In response to this pressing challenge, the Kenya Society of Hematology and Oncology, KESHO, was founded in 2002. Since then, KESHO has been at the forefront of enhancing clinical care and treatment for cancer patients in Kenya. Another round of applause for KESHO. We commend KESHO for its unwavering dedication to bringing together a diverse range of specialists, medical oncologists, oncology nurses, clinical oncologists, medical physicians, and radiation technicians to advance knowledge and practices in cancer care. Through your active engagement in research, you have consistently improved outcomes for cancer patients, staying true to your mission of improving the outcomes for patients with cancer and blood disorders. The program lineup for this conference has been nothing short of remarkable. The speakers, the sessions, the cutting-edge research presented by internationally acclaimed researchers and doctors reflect the exceptional talent and dedication within this ecosystem. I'm confident that the knowledge shared here will lead to tangible improvements in cancer care for our people. A special mention goes to the youngest presenter. I think we have given an award, Dr. Jean Kasudi. I'm not sure if she's here. She's not here, but we really do say congratulations for that abstract that she has presented. My remarks were very short. In closing, I commend KESHO for its tireless efforts to advance cancer care and research. Together, let us remain steadfast in our mission to improve the lives of those affected by cancer and strengthen the health systems that serve our communities. Thank you very much.
At this moment, I would like to invite the conference chair to come at the podium to give us a vote of thanks.
Good afternoon, CEO KUTRH, Mama Nyongo, First Lady of Kisumu, Interim President KESHO, Aortic President, all protocols observed. Good afternoon, everyone. I think we still have a full hall on day 3. I think that's an achievement. Please, let's clap for ourselves. I feel like this week has been testament to what teamwork can do. It's a testament to that we are very proactive in terms of education. We are proactive in terms of handing over the mantle so that the work continues long after we stop doing the work. We have seen collaboration from different areas of people who work in the oncology space. And I'm happy to say that the next generation of oncologists and oncology workers in Africa is safe. Moving forward, I think our call to action is we are not stopping the work. The conversation has to continue. The work has to continue. We are looking forward to our next conference in 2 years' time. Again, as our president has guided, we will be looking for people to step up so that we can do the work together. With that, I want to thank everyone for your participation, all our partners, all the people who have worked tirelessly for the last week to deliver a worthy conference, and we're looking forward to the next one. With that, we will close, and we see you in 2 years' time. Thank you very much.
Some few announcements. We have some lost cards, so maybe somebody is looking to the room card. So room number 412, if you're looking for your card, it is with us. We also have some lost items which were found. So there were keys with national ID, with 2 packs and denim jacket in Rambala. So like anyone who has lost that, you'll come to us. Okay. So at this moment, I would like to invite all the award winners to come here to come and have a group photo. All the award winners, the best poster abstracts, oral presentation, and our faculty who are awarded, please welcome to the stage.